Good morning everyone. Today we are going to talk about the dislocation of shoulder joint. As we all know, it is the commonest joint in human body that goes for dislocations, and it is most commonly seen in adults as compared to the children. It is the common joint for dislocation because it has shallow glenoid socket and there is extraordinary range of movement in this joint, and there is presence of laxity, and it is very much vulnerable during stress. Now let's talk about the types of shoulder joint dislocations. As we can see, this is the head of the humerus which just fit in the glenoid cavity of the scapula, and we can see that it is normally fitted in the glenoid cavity, but in shoulder dislocation, if this head of the humerus gets dislocated anterior to this glenoid cavity, then it is known as anterior dislocation, whereas if the humerus head goes behind, that is posterior to this glenoid cavity, then it is known as posterior dislocation of shoulder joint. And if this humerus head goes inferior to this glenoid cavity, then it is known as inferior dislocation. As we can see here, this is the scapula, and this is the coracoid process of scapula, and this is the acromion process of scapula, and this is clavicle, and this is the glenoid cavity where the head of humerus fits. This anterior dislocation of shoulder is further subdivided into preglenoid, subcoracoid and subclavicular. Now talking about the preglenoid, the head of the humerus lies in front of this glenoid cavity. It just lies in front of the glenoid cavity, and in subcoracoid dislocation, the head of the humerus lies below this coracoid process. The head of the humerus lies below the coracoid process, and in subclavicular type, the head of the humerus just lies below this clavicle. So these are the three types of anterior shoulder dislocations, and they are preglenoid, in front of the glenoid, that is preglenoid, subcoracoid, below the coracoid, and subclavicular, that is below the clavicle. As we have already discussed the types of dislocation of shoulder joint, and they are anterior dislocation, posterior dislocation and inferior dislocations. And anterior dislocation of the shoulder joint is the most common one, and the mechanism of injury is when a person falls on outstretched hand with shoulder abduction and externally rotated, then this injury can happen. And when there is blow on the proximal humerus head, then it can go under anterior dislocation of shoulder. And in this head of the humerus comes out of the glenoid cavity and lies anteriorly. So in this type of dislocation, the head of the humerus comes out of the glenoid cavity and lies anteriorly, and it is also subdivided into preglenoid, subcoracoid and subclavicular, that we have already discussed earlier. As we have already discussed, preglenoid is that type where the head of the humerus lies in front of the glenoid, whereas in subcoracoid, the head of the humerus lies below coracoid, and in subclavicular, the head of the humerus lies below clavicle. Now moving on to the posterior dislocation of shoulder joint. In posterior dislocation of shoulder joint, the head of the humerus lies posteriorly behind the glenoid, and it may result from direct blow on the front of the shoulder. So it can result from direct blow on the front of the shoulder, and more often it is the consequence of an electric shock or epileptiform convulsions. And now talking about the inferior one, it is also known as luxatio erecta, and it is a rare one, and in this type of dislocation, the head of the humerus lies subglenoid, that is below the glenoid cavity. Now let's talk about some pathological changes which are very much important in shoulder joint dislocations, and they are Bankart lesion and Hill-Schacht lesion. Bankart lesion is nothing but it is the avulsion It is the avulsion. It is the avulsion of anterior-inferior labrum of the glenoid rim. As we all know, labrum is a rim. This labrum is a rim of soft tissues or fibrous cartilage that give support to the shoulder joint, and the ligaments that stabilizes the joint are attached in this labrum. And when there is avulsions of the anterior-inferior labrum of the glenoid rim, that is anterior-inferior, anterior and inferior, when there is avulsion of this anterior-inferior labrum of the glenoid rim, it is known as Bankart lesion. And if this is associated with glenoid rim fracture, and if fracture is also associated with it, then it is known as bony Bankart. And now talking about the heel sac lesions. Heel sac lesions are nothing but the depression of the humeral head. These are the depression. Look at this. This is the depression on the humeral head in the posterolateral aspect. So, heel sac lesions is the depression on humeral head in the posterolateral aspect. So, these two are the main pathological changes that occurs in shoulder joint dislocation, and they are Bankart lesion, that is avulsion of the anterior-inferior labrum of the glenoid rim, and heel sac lesion, that is depression on the posterolateral aspect of humeral head. So in this way we have discussed about Bankart lesion and heel sac lesion. Heel sac lesion is present in posterolateral aspect of this humerus head. Now moving on to the other pathological features, we can see the rounding of the anterior glenoid rim as well in chronic cases, and it can be also associated with injuries like rotator cuff tear and fracture of greater tuberosity, and there could be also rupture of anterior capsule as well. So these are the pathological changes, and they are Bankart lesion, heel sac lesion, rounding of the anterior glenoid rim associated with rotator cuff tear and fracture of greater tuberosity, and rupture of anterior capsule. Now talking about the diagnosis, the presenting complaint will be the patient presents with a typical deformity, that is shoulder abducted and the elbow supported with opposite hand, like this. The patient will present with shoulder abducted and elbow supported by the opposite hand. The elbow is supported by the opposite hand. So this is the typical presentation of the shoulder joint dislocation of the patient, and they also say that they have a history of fall on the outstretched hand, which is followed by pain and inability to move. And in case of recurrent dislocations, the history of similar episode is present in the past. And talking about the examination, the patient keeps his arm abducted. And the normal counter of shoulder joint is lost and it becomes flattened. And on careful inspection, there is fullness below clavicle. Now let's see in this picture. The patient kept his arm abducted. The arm is kept abducted, and the normal counter of this, look at this opposite side. This is the normal counter of the shoulder joint, but in the affected hand, there is flattening of the shoulder. And if we carefully see, then there we can see the fullness below clavicle. So these are some features we can see on examination, and they are: the patient keeps his arm abducted, the normal counter, that is round, of shoulder joint is lost and it becomes flattened, and on careful inspection there is fullness below clavicle. Now let's talk about the clinical test for acute dislocations. First of all, we are going to talk about Dugas test. Dugas test is nothing but the patient is asked to touch the opposite shoulder, that is unaffected shoulder. The patient is asked to touch the unaffected shoulder by the affected shoulder, but the patient is very much unable to touch the opposite shoulder, so it gives Dugas test positive. And now talking about the Hamilton ruler test, because of the flattening of the shoulder, it is possible to place a ruler on the lateral side of the arm, and this touches the acromion and lateral condyle of humerus simultaneously, so this is positive. And talking about the Regiment batch test, regiment batch test is done to know the situations of the axillary nerve, to know whether the axillary nerve is intact or injured, and if there is the area of anesthesia around the deltoid, then axillary nerve is damaged. And likewise, Bryan's test, Calaba's test can also be done. And for recurrent dislocations, apprehension test, drawer test, sulcus test, and relocation test can also be done. Now talking about the investigations, we have to do the X-rays, and in X-ray we have to do the X-ray in two views, that is AP view and lateral view. Lateral view is also known as the axillary view, and in AP view we can see the overlapping of shadows of humeral head and glenoid fossa, and we can also see the Hill-Sachs lesions here. And in lateral view, humeral head has come out of the line with socket. We can see that humeral head has come out of the line with the socket in lateral view, and we can also do the MRI or MR arthrography for demonstrating the bone lesions and labral tear, and also we can do arthroscopy. Now let's talk about the treatment of shoulder joint dislocations. As we all know, shoulder joint dislocation is an orthopedic emergency, but one must rule out the axillary nerve injury and fractures and rotator cuff tear before treatment. So before treatment, we have to rule out that if there is presence of axillary nerve injury or not, if there is presence of any fractures, or if there is presence of rotator cuff tear or not. Then we can go for conservative treatment or surgical treatment. First of all, we will go for conservative treatment, and that is, and under conservative management or treatment, first of all we have to do the reduction under general anesthesia, and reduction under general anesthesia can be achieved by Stimson's gravity technique, Hippocratic technique, Milk technique, and Kocher's technique. And then after reducing the dislocations, we are going to check the stability by doing the Dugas test, X-rays and abduction. Then we will apply cuff and sling to the joint, and we will tell the patient for some movements. So this is the Stimson's gravity technique, where the patient is made in prone position, and in this affected arm the weight is applied in this affected arm. So this is the Stimson's gravity technique, and this technique will help to reduce the shoulder joint dislocation. And now talking about the Hippocratic method or technique. In this technique, the practitioner grabs the affected hand of the patient. First of all, the patient is made in supine position, and the practitioner grabs the affected hand and puts it heels on the axilla so that the dislocation can be reduced. And this is the Hippocratic technique. Now let's move on to this Kocher's technique. In Kocher's technique, first of all, traction is given with external rotation on the hand, on the affected hand. First of all, traction. Traction is given with external rotation in the affected hand, and then the hand is adducted, and it is internally rotated. So first of all, we are going to do traction and external rotation on the hand, and we will do adduction and internal rotation. And this is the Kocher's technique, which is used more oftenly and is very much helpful for the reduction of the shoulder joint dislocation. So these are the techniques, that is Stimson's gravity technique, this is Hippocratic technique, and this is Kocher's technique. After the reduction, we are going to check the post-reduction stability by Dugas test. As we have already discussed, we will tell the patient to touch the opposite shoulder and we will do the x-rays to see whether the joint has been properly reduced or not, and we will tell the patient to do abduction. And after that, we will apply cuff and sling to the patient, and if the patient is less than 30 years, then we will tell the patient to use the sling for 3 weeks, and if the patient is more than 30 years, then we will tell the patient to use the sling for 1 week. And talking about the movements, we will tell the patient to avoid combined movements such as abduction and lateral rotation for 3 weeks, but we will tell the patients to practice the movement of elbows and finger every day. And now talking about the surgical treatment, arthroscopic anterior stabilization surgery can also be done, and for recurrent dislocation of the shoulder, putty-plate operation, Bankart's operation, Bristow's operation and arthroscopic Bankart repair can also be done. Now talking about the complications can be early and late, and in early complications there could be rotator cuff tear, axillary nerve injury, axillary artery injury, and the fracture of greater tuberosity can also be seen, and the fracture of acromion or coracoid can also be seen. And in late complications, there will be shoulder stiffness, there will be unreduced dislocation, traumatic osteoarthritis, pathological lesions like Bankart lesion and Hill-Sachs lesions, and there could be recurrent dislocation syndrome. And now talking about the posterior dislocation and inferior dislocation in brief, the mode of injury is in internal rotation and adduction position, and it is most commonly seen in convulsions and electric shock. And in X-ray findings, there will be absence of normal elliptic overlap, there will be electric bulb sign, empty glenoid sign and TRAW sign. And the treatment can be done by the traction under general anesthesia and by the application of the airplane sling. And the complications could be reverse Bankart lesion and reverse Hill-Sachs lesions. And now talking about the inferior dislocation. In inferior dislocation, the mode of injury is in full abduction and elevation and severe hyperabduction injuries. Thank you.